like sunshine, like springtime, like something's in the water and I'm taking a deep dive. I'm feeling so weightless, like I'm gonna make it, and nothing in the universe can take this. I can see it clearly now, nothing gonna bring me down. I got my head held high, I'm on my way, and I'm following the signs to my happy place. I'm walking in the light of a brand new day, and I'm right where I belong in my happy place. I got my head held high, I'm on my way, and I'm following the signs to my happy place. I'm walking in the light of a brand new day, and I'm right where I belong in my happy place. And I'm right where I belong in my happy place. And I'm right where I belong in my happy place.
Welcome to the National University of Singapore Yongloo Lin School of Medicine Healthy Longevity webinar series. You know, I've been waiting to screw that up because it's such a mouthful, and I got through 17 episodes before I did it. So not too bad. It's a great night because we have with us Andrea Maier here to speak about aging, but the exciting thing is that she will be joining us next month as our clinical director of our Center for Healthy Longevity. So we can talk to her a little bit about what she wants to do in Singapore. I want to remind everyone to use the Q&A function to ask questions, and we'll try to get to those as we have time. And before we get to Andrea, I've asked Rachel Koh to talk about a recent paper, and she chose one looking at vitamin D supplementation and omega-3s in strength training exercise programs in older adults. Rachel?
Greetings, esteemed guests. As Brian has mentioned, I am Rachel, and today I'll be presenting a research article by Bishop Ferrari and colleagues on the effectiveness of omega-3 supplements, vitamin D supplements, and strength training program for elderly over the years of 70. So here are the following research objectives from the article. As mentioned, the participants will be elderly, 70 years and above. And the research aimed to find out whether vitamin D supplements, omega-3 supplements, or strength training exercise can improve cardiovascular health as measured by diastolic blood pressure change, bone health as measured by the number of fractures incurred by the participants over the course of the study, muscle health as measured by short physical performance battery, brain health as measured by Montreal Cognitive Assessment, and immunity as measured by the number of infections incurred by the participants over the course of the study. So here are the following research design. This is a randomized double-blind placebo-controlled trial with a 2x2x2 factorial design. So there are 3 independent variables. The first independent variable is vitamin D dosage. Participants are either randomly assigned to receive a dosage of 2000 IU per day of vitamin D or placebo vitamin D. The second independent variable is omega-3 supplements, where the participants were either randomly assigned to receive a dose of 1 gram of omega-3 per day or placebo omega-3. And lastly, the third variable is strength-based exercises, where participants were either randomly assigned to complete a strength-based exercise for 3 times per week, each time for 30 minutes, or an attentional control exercise program focusing on joint flexibility for 3 times per week, each time for 30 minutes. Over the course of the study, participants were followed closely for 3 years, where during the 3 years they include yearly clinical visits and telephone call from the researchers every 3 months for an update. So here are the results. Overall, it is found that there is no significant improvement of health outcomes across all treatment groups when compared to placebo controls, nor is there significant improvements when treatment modalities are combined together. Additionally, during the 3-year follow-up, there was a significant decrease for muscle health, but significant improvement for brain health across all participants, regardless of conditions or independent variables assigned. Interestingly, vitamin D supplements seems to benefit elderly men who has decreased systolic blood pressure upon treatment, while omega-3 supplements helps reduce infections for participants who naturally has high EPA and DHA levels in the body. Thus, taken together, unfortunately, this study concludes that vitamin D and omega-3 supplements and strength training exercise do not support for clinical health outcomes. However, given the last point, it seems that vitamin D supplement and omega-3 supplements may benefit a subset of the population, which are namely elderly men and elderly who has high levels of EPA and DHA levels naturally in the body. And with that, I've come to the end of the presentation. Thank you.
Thanks, Rachel. Andrea, I'll go ahead and introduce you, but I want to just ask you a question about that last study, because I think it points out one of the challenges with clinical studies in older individuals. But first, perhaps I'll introduce you. Andrea is in 2012, she was appointed the head of section of gerontology and geriatrics at Vrije Universiteit. I know I got
Vrije Universiteit.
Close enough, huh? Hopefully. In Amsterdam, and became a full professor in 2013. Since 2016, she was a professor in medicine and aged care at the University of Melbourne. As I said, and very excitingly, she will continue her career here as the Un Chu Sing Professor in Medicine and Functional Aging at NUS. So first of all, welcome to Singapore, almost.
Thank you.
You'll be here
Thank you.
next
As you
month,
know,
right?
I'm already working, of course, for Singapore as a visiting professor. So I'm really enjoy it. And I really look forward to my flight in May.
That's great. I'm looking forward to working together. Hopefully, if we do another show in 6 months from now, we may be like screaming and yelling at each other. But right now, I think it looks good. So, I think like just before you start your talk, I think, that last presentation, I think most of us think strength training is a good thing for older individuals. The question is, I think it points out the complication in how you set up a clinical study to try to show efficacy for something like exercise. And, I'm putting the cart before the horse, but I'll go ahead and ask you a question. How do you solve that problem?
Difficult. So aging is quite difficult, and there are more domains than just, for example, muscle health, which makes you healthy. So I think that's also the problem of this study, because it focused on supplementation and then on strength training. And look, it's a brilliant research group, and they have the best methodologies, and this is the best quality you can get. I know the group quite personally, and it's very high standard. So, but what it shows, because it's so disappointing, I think we have to say it's very disappointing, is that we have to take lots of other components of the human body into account while designing trials, and also take into account that sometimes we have to make trials longer or shorter, and maybe also we have to choose different outcomes. So quite disappointing, and we can learn from it a lot. That's also the reason, I think, why it's published in JAMA.
Yeah, no, it's a very interesting study, even though it's a mostly negative finding. All right, so Andrea, your talk is on bringing geroscience to clinical practice. So I'm excited to hear what you have to say.
Thank you again for inviting me to this talk. And I titled it Bringing Geroscience into Clinical Practice because that's really dear to my heart. As you know, I'm a clinician, and I love to make my patients clinically, in a relevant way, healthier. And I think that the current healthcare system is not prepared doing that. And that's the reason why I think we have to invest in geroscience. First of all, as everybody knows, lifespan is increasing. I just depict here the values for men in this case. And what you can see is that we have a compression of morbidity, and there was also mortality. So we will die at not only an older age, but also at nearly not nearly, but more at the same age. So there was a higher variability at earlier decennia, for example, in the 50s, in the 60s. So why is that happening? And of course, this is not only happening for males, but also for females, because we have a quite safe environment, and we built that since the 50s and also earlier. And we have excellent hospitals, we have excellent healthcare professionals. And of course, with the hospitals and the healthcare professionals, we have the excellent care. And that means that we have drugs and we have surgical interventions. And that makes us staying longer, but maybe not healthier on Earth. And that might be a problem, and that might need a different way of thinking. And there, of course, Geroscience kicks in. So the sense, if we are staying on Earth, so more longer, and we don't die, that also our population is changing. Here you see the worldwide data, how many of our population are 60 and older, or 80 and older. And what you can see, also the prognostication about the next coming decennia, is there's a huge amount and a rapid increase of the number of individuals at the age of 60 plus and 80 plus. And especially you see that Asian countries have a boom in the numbers of older individuals. This might not be a problem, and it should not be a problem, because actually it's a result of excellent healthcare that we don't die. But the problem is that we are growing old with lots of multimorbidity. And as you might know, multimorbidity is defined as 2 or more chronic diseases, and comorbidity is if you have one disease and you have another disease. And 60% of the 60-year-olds have at least 2 or more chronic diseases in the Western countries, and at 70% suffer from multimorbidity. And that might be a problem because, of course, all these individuals need also the care in the healthcare system. I would like to show you a very nice study of Davide Vetrano, who actually looked at, if somebody already has a disease, what is the trajectory of multimorbidity and what occurs first. And he looked within the Swedish National Study on Aging and Care, and included individuals around about the mid-70s. And the outcome was deaths, you are seeing here. And what he did very nicely, he looked at specified clusters of diseases. But what was he able to identify is that if you have, for example, cognitive and sensory impairment, then it's very likely that you are dying in the next coming 6 years. But it's also likely, if you don't die, that another thing occurs, and that's multimorbidity, even more morbidities. And it's very likely that these individuals with already cognitive and sensory impairment, they have, for example, respiratory diseases. So it seems that clusters occur, and then another disease occurs based on that cluster. If we look at heart disease, a very frequently occurring disease at older age, then also a majority is going to die within the next 6 years. However, it's very likely that these individuals develop cognitive impairment and develop dementia. And of these, then also the next clusters occur after another 6 years, which means that we can quite nicely already, if I go back, quite nicely predict what's going to happen if a certain disease already exists. So we now have in hands not only that morbidities and multimorbidities occur with a higher age, but also how they occur, which is important to know. So we are growing older as a population. We are growing older with diseases, and then, of course, Geroscience kicks in. And the aim of Geroscience is to increase the health span and to decrease the time with age-related diseases. And that's very nicely, very simply quite depicted here. Today, I, as internal medicine specialist, I see my patients at the age of 50 to 60 when they have cardiovascular diseases, metabolic diseases, and then most of the times they stay my patients because these are chronic diseases, and they will also develop other diseases, and their history of having age-related diseases increases. What Geroscience really wants is an optimal longevity and a very narrow, tiny section of life with age-related diseases. How can we do that? And would it be possible actually to minimize the time with age-related diseases? Yes, we can, because in the last, I would say, 20 years, we now understood how we age, and we understand bit by bit the mechanisms of aging, as for example, cardiologists bit by bit understood in the last 50 years how the heart works, or neurologists how the brain works. So if we talk about the mechanisms of aging, you see the 9 hallmarks of aging in the center. And this is, of course, the mitochondrial dysfunction, the epigenetic alterations, genomic instability, senescence, etc., etc. But we now also know that these 9 hallmarks, they are working together and they're interfering with each other. And we also know, which is quite nice, and that's really the development of the last 5 to 10 years, that environmental influences can actually interact with these hallmarks of aging. And the hallmarks of aging, they might occur differently at different ages of our life trajectory, which is also, I would say, the development of the last 5 to 10 years. So, and if we know why and how we age, we could also identify the ones who are aging faster and slower. So identification in my talk is one of the keywords I'm going to use. And we can intervene. And I just brought one example of Brian Kennedy's group he just published, giving to mice alpha-ketoglutarate. And there was trying to enhance their lifespan. Yes, and it was possible. You see on the upper panel that in females, they had a longer lifespan while getting that supplement, and it was less pronounced in males. So now we have, and this is just one example of thousands of examples, especially in animal models, that we can extend not only lifespan, but also health span in animal models. And they're the first results in humans, which we might want to bring into clinical practice at a certain time. So we can identify and we can intervene. However, so it's not really yet based on clinical practice, or it's not implemented in clinical practice. And there was a very nice article in GMJ most recently with the title Geroscience Coming of Age. So really stating, yes, there is the opportunity to handle care and health and cure differently. We have to integrate geroscience into our clinical thinking. However, there is a huge lack of knowledge, but there's a huge opportunity. So I would like to discuss a little bit with you how we could actually decrease the lack of knowledge and using the opportunity in the next coming 5 to 10 years in our healthcare systems, or how we could integrate as researchers this into our daily business doing research. And I would like to show you first why I think it's so difficult to implement geroscience into clinical practice, because our healthcare system is so established and so well established and so good with so good results that it's hard to bring something else in, because we have segments within the healthcare system who are dealing with single organs like the heart, the brain, the pancreas, the joints, etc. And we specialized so much. And we were able to sometimes cure, but most of the times care for the single organs so well. But what we haven't yet done is actually to prevent the next age-related diseases, because we didn't tackle the real pathophysiological mechanism, which is given here. So we now have a great healthcare system we should be proud of, with a very nice result of increasing the health span and the lifespan, especially the lifespan with, for example, vaccinations, the health span. But in the end, I think we have to cure our healthcare system a little bit differently by bringing geroscience in, and there we're slowing the age-related diseases down to occur, and maybe bringing biogerontologists, clinical biogerontologists in. And I would like to show you an example how implementation in healthcare system is going to occur by showing you the example of osteoporosis and sarcopenia. I did lots of research in sarcopenia, which is the low muscle mass, muscle strength, and physical function. And while doing so in the last 15 years, we always looked at the osteoporosis field. to see, okay, what can we learn from the osteoporosis field to be able to implement sarcopenia more successfully. And what you can see here is that the osteoporosis, there was a first definition in the 40s, there was available medication, there was pharmaceutical interest, which is very important, and there was a WHO definition, and now really in the last 20 years, it's really implemented into clinical care. If we look at sarcopenia, it's a much, much younger disease. There was a term coined in the 80s, and there was a first definition in the 90s. And then really there were interventions, and we were able to have even more definitions, more accurate definitions, and we got an ICD-10 code, the International Classification of Diseases, which is very, very important to implement disease into a healthcare system. If we are looking at aging, I think the first success is already there, that there is, for aging-related conditions and diseases, there is an ICD-11 code, which is nice. But what you can see is it costs lots of time to implement it into the clinical practice, to get used to it, and to have the right healthcare path systems. We did a little bit of research in the sarcopenia field to see, okay, how can we implement it? And what I can say is, and I think we should also do that in the aging space, we have to work together. Worldwide, we have to work together, because to reach healthcare professionals, you really have to give lots of presentations, you have to write lots of guidelines, and then you need KPIs to act on it. And we published that there's lots of lack of knowledge and in sarcopenia in that space, but it's the same for geroscience in the community, and especially around healthcare professionals. So if we want to change the management of individuals with a certain disease, like sarcopenia or like age-related conditions or aging-related conditions, to use that ICD-11 code, we have to really work together and, for example, make roadshows as we did at a certain time. And I just showed you two examples through studies that the lack of knowledge is not only present in the Netherlands, where it is the first study, but it's also present in Australia and New Zealand. So it's a worldwide problem, and therewith, I think we should really work together worldwide and engage in that. And I think engaging is not only important for healthcare professionals or with healthcare professionals, but also with the community and community-dwelling adults, because these are the ones who experience not only sarcopenia, but also aging. And once we deliver the knowledge and we actually say what we can do, then the willingness to actually interact and to have a treatment most of the times is very, very high. So the first thing, while you are looking at Soudek, which is a very nice photographer here in the Netherlands, really showing his mother at different ages, and this is such a beauty. I would like to show you a couple of slides about how could we identify individuals who might suffer from a faster aging trajectory, and we might want to intervene with. So here you see a very often used slide that the pace of aging is quite different in a population. We have slow agers and we have fast agers. And at old age, it's very, very easy to identify these individuals at the age of 80, for example, who is a slow ager and who is a fast ager. And that's very, very easy, and geriatricians especially can do that quite quickly. However, what we can do, for example, in internal medicine, is identify individuals already at the age of 60 or 70 who might have activities of daily living decline later in life. So that's actually, we can prevent it. And we worked quite enormously in European consortia to make prediction tools to identify the ones at risk for a detrimental outcome later in life at the age round about 60, and they are all available. However, they are not yet used in clinical practice. And I just show you one of the results where we looked at a 10-year follow-up to actually see if we can predict functional limitations in individuals, females and males, at the age of 60 to 70. And we were quite lucky to be able to identify quite nicely the group with an intermediate risk of functional limitation. So we can identify individuals. But however, we can already identify individuals at the age of 30, for example. This is a very beautiful Dunedin study actually showing that already at early ages, there are changes in the human body which can be measured in a clinical way. Every GP can do that while aging is occurring. So the function is declining already at the age of in the 20s and in the 30s, and we can measure it. And even looking at somebody, looking at facial images, for example, here at the age of 45, we can already identify the individuals at risk. And all these markers are already associated at that age with diseases. However, clinical markers, if using clinical markers is not enough, I think really now is the time to combine the biological markers we have, looking at the hallmarks of aging, and combine them with the comprehensive geriatric assessment. Or if you would like to, at earlier ages, to combine it, for example, with metabolic markers, cardiovascular markers, etc. So therewith, we coined a couple of years ago the term biological geriatric assessment. And one of the hallmarks of aging is senescence, and we already know senescence might be a marker you would like to take into account. Here we show that senescence in a very big meta-analysis using all the data worldwide, looking at senescence and chronological age, that there is a huge and a very significant association between senescence load and chronological age, and that's nearly in all different organ systems present. And especially the association between senescence load and age, is especially there between the pancreas and in the brain, in the heart, and in the lungs. So these are the organs where age really is a huge determinant of senescence load in these organs. And if you look at the markers being used, especially the DNA damage markers are highly associated of age and in the different organs, and also the cell cycle regulators and beta-gal and the senescence-associated secretory phenotype. So we have the markers in place, and we just have to trial them in human beings a little bit broader. And we also know, for example, that senescence is associated with facial aging. We looked at the inner upper arm and looked at senescence, in this case P16, and looked at wrinkle grading, and we looked at perceived age. And what you can see is the ones with more wrinkles and the higher perceived age have more senescent cells in their inner upper arm. And we also know that senescence is associated with age-related diseases. This has been published recently. You see horizontally the different senescence markers and all the other diseases vertically. And what you can see, blue, is there is a significant association of having a higher senescence load in the different organ system who actually have a disease compared to a control. And what you can see, there's lots of blue, and there are lots of studies already. So we know that senescence is associated not only with age, not only with your outer phenotype, with how you look like, but also with age-related diseases. So we know how to identify. I think now we really have to step into the clinical cohorts, and please have a look at the former presentations by two brilliant researchers about epigenetics. So what do we know about the intervention? We know that, and can we already apply it? So we know that lifestyle is really interfering with the hallmarks of aging. Think about sedentary lifestyles. Think about diet we do. Think about the lack of healthy nutrition. So we already have that knowledge. So how can we actually use it? And we also know that if you do, and if you perform a life with a healthy lifestyle, that we have a much longer health span. So these are data of the Rotterdam study really showing that if people perform a healthy lifestyle, that they live 6 years healthier and luckily also longer. And cells love movement. I like this study because it was one of the earlier ones really linking physical exercise to biological markers, where they did treadmill training in nearly 60 individuals at the age of round about 60. And they did that for a couple of months. And what they were able to show, if you do the treadmill training, you have longer telomere lengths in your blood cells, higher telomerase activity, and less senescent cells in your blood. So that's nice. But then on a more clinical level, the question arises, okay, what should we do? Is treadmill training the activity we should do? And that's the reason why we invested a couple of years now to look at objective physical activity and sedentary behavior. and related the objective, so measured objectively with an accelerometer, the behavior to certain outcome parameters. And I have a lovely group of early and mid-career researchers who did this work, which are nearly all are published now. So horizontally, you see steps, the activity counts, total physical activity, and then the mid to vigorous physical activity, low physical activity, and SPE is sedentary behavior. In the darker color is a higher standardized effect size within the outcome. And the outcomes are mortality, ADL, frailty, falls, etc. And larger circles means that there's a higher standardized effect size. So that's important. What you can see already, that's eye evidence that steps are counting. So you have to make steps to have or to avoid these detrimental outcomes. And what's also very important is that if you do the steps, MPPI, so the mid to vigorous physical activity, might be the best physical activity you should choose. But every step counts, and that's very important. We are now guiding the WHO to actually to write the guidelines based on these results. And please watch the video of the presentation of Beatrix Verreiken in December. And she really showed how we can implement already physical activity in the daily life to all make silly walks on the streets, therewith enhancing our physical activity. But physical activity and sedentary lifestyle and intervening with it and intervening with lifestyle is not enough, I think. Repurposing of drugs is very important because drugs, they are available. If we repurpose them, they have known mechanism, they are safe, and most of the time they are cheap. So that's very important. And we invested quite a lot in the last couple of years to see, okay, what kind of drugs should we actually apply and where's the most evidence? And we haven't looked as an outcome, an aging outcome. We have looked for cognition because cognitive outcomes have been used much more compared to a non-defined aging phenotype. So that's the reason why I will show you in my last minutes a couple of studies where we actually draw our conclusions from what maybe to use in our next trials. And what we can see here are drugs in the proteostasis mechanism. And what you can see here are animal studies and human studies on the left-hand side, the animal ones on the right-hand side, the human ones. What you can see is everything is green is a positive result and black is a negative result. There are lots of positive results already using animal studies in using these kind of drugs, and there are a couple of studies already in humans. On the other hand side, if we look at insulin signaling pathways, there are lots of evidence already looking at animal studies which are quite positive by repurposing these kind of drugs if we look at the outcome cognition. And we divided it by studies looking at prevention and the other ones looking at cure. But what you can see is if you look at the human studies, that yes, there are lots of human studies already, however, they are quite negative. So I think we have to find another way how to combine drugs or even make it more specific. And of course, these are just based on outcomes, based on cognitive outcomes, and not aging in general. And of course, please also look at the seminar of Nir Barzilai in March. He, I think, has a wonderful prototype, and that's TIME, giving metformin to individuals at the age of 60 to 70 to lower the expected frequency of cancer, CVD, dementia, and mortality. However, I would like to really urge Nir also to think about, couldn't we actually trial these kind of therapies already earlier in life, and might be the age of 60 to 70 be not too late. The last thing I'm going to show you is that we are also working at the moment based on the outcome cognition on GSK3 inhibitors. We looked at the literature and thought, okay, might GSK, the pathway, be a one to target, because we know that it is involved in selective phosphorylation of substrate, and under this substrate it's also tau, and tau is associated with the development of dementia. So what we did, we looked at lots of herbs and different drug classes and so, okay, do we find literature actually showing that inhibition of GSK3 might actually help to cognitively health, to age cognitively in a healthier way. And here you see the results. There are lots of animal studies already and one human study, which already used a drug, which is FDA approved. But what you can see is if you look at the outcome cognition, there is lots of positive results already. So to close my lecture, there's an identification. I think we understand at least a little bit how we age. We could identify it. So we really should invest in identifying biomarkers for the biological age. We already have interventions in place, and that's lifestyle interventions. And let's trial them together with our repurposed drugs and new compounds to make people healthier. And that's so lovely to actually do that in Singapore together with you, Brian. I think there's a lovely structure to enhance human potential across the human lifestyle. On the right-hand side, you see our domain, the healthy longevity domain. But I think it's very important also to look at younger ages and look at maternal and infant health, etc., to really tackle this aging, not a problem, but this adventure, having a trajectory in life together. Thank you very much for your attention.
Thanks, Andrea. I really want to reemphasize one of the things you mentioned. I think at the end of the day, this is really going to be a life course approach to health span. And a lot of us are looking to do interventions in middle age or even later now, but ultimately, it's really something we should be doing throughout the life. And I think that, we typically have this mindset still based on Hippocratic Oath that we should do no harm, and that means don't do anything to healthy people. But I think we have to rethink that, because not doing things when people are healthy is actually hurting them. We should be looking at how to preserve their health and improve their function, I think, earlier. I don't know if you agree with that.
Look, it's dependent on how you define health. And normally we define health based on symptoms we have or conditions being diagnosed. And I think I feel quite healthy. However, of course, I'm aging, and phenotypically, you can also see that. So we have to intervene much earlier before symptoms occur and before we realize that climbing the stairs, for example, is a little bit too difficult at certain points. Or running a marathon or running whatever. But we all know that our cognitive, or I think we feel, the ones who are listening older than 35 years of age, hopefully you have also the feeling that, not hopefully, but that your cognitive and physical capacity is declining at the moment.
I love that slide on trajectories, because we talk about, getting one chronic disease and then getting another one. But what you're really saying there is that these diseases are not just random chances, that having one chronic disease can specifically direct you down a path toward others. For instance, cardiovascular going to neuro, that's not necessarily obvious. How much can we learn from looking at those trajectories and what that might tell us even about hallmarks of aging?
I think a lot. I would say 10 years ago, we thought, okay, there is one hallmark of aging, which is actually then interfering with aging, and that's a clue. But I think that's not the case. We can already phenotypically see, and that's very nicely shown in that study, that there are certain biomarkers or certain pathophysiological mechanisms then leading to another disease. And it's very obvious if you have heart failure. Then most of the time, either the blood pressure is too high or too low. But if it's too low, then also the circulation in the brain is going down. And there with dementia or cognitive impairment is going to occur. On the other hand side, if a blood pressure is too high, and that's the reason for heart failure, most of the time there's already so much white matter hyperintensities and damages that's the leading cause for cognitive impairment. So it's very logical what's occurring. And what we don't do in clinical practice at the moment to actually prevent that next step, because the cardiologist is looking at the heart and the neurologist or the geriatrician is looking at the brain. And I think that's also within healthcare the next move to prevent the next comorbidity.
I mean, how do you roll back that specialization, though? I mean, we've been going toward more and more specialization, and there's good reason for that. We need people with expertise in specific conditions. But now, I think we've in some ways we've gotten too far down that path, and we're missing the forest for the trees. I don't know how you put all that back together, though, from a clinical perspective.
I think it's already occurring. If you look back in the last 15 years, there are much more geriatricians, if you look at the older age groups, who are actually taking care not only of the brain or of frailty, but they are interfering much more with subspecialties, which is very nice. But what I also see, at least in the European countries, that for early ages, at the age of 50, 60, internal medicine specialists also de-specialize. And there is much more room for the general doctor now, not only in the community, but also in the hospital, because we created so much comorbidities and multimorbidities that one doctor is actually cannot handle it. And therewith we need the input of all the specialities, but with one physician overseeing that. So it's not only at older age, but also at middle ages, we see that direction within healthcare at the moment, which I think is very good.
You need one doctor to rule them all.
Not sure. Because there's not sure if you have to see the big books of internal medicine if one brain can capture all the diseases.
You mentioned ICD-11 codes, and we haven't really talked about those on the show before. So, and the WHO lists age-related conditions. So, first of all, can you explain ICD-11 a little bit more, and then tell us what age-related conditions really means from a clinical perspective?
Yeah. First of all, physicians always work with the International Classification of Disease, because if there is no disease, we think as physicians there's nothing to do. So we need that big book of lots of numbers and abbreviations to be able to do something. So the first step in clinical care on the clinical world is having a number, a code. And that's the International Classification of Diseases. And then there are different definitions attached to that code to be able to think, can I do something with it? And then, of course, there is money attached to that most of the times, because then you can also claim your intervention or your diagnostics you did. So that's very important. So it was very important for the sarcopenia field, and now it's very important, I think, for the aging field. Look, it's aging related, which is nice. I really like it because it's not age related. So that means that biological age, we can play with aging, which means that aging related conditions. So if you have a slower gait speed, for example, or you have, and there was in the end sarcopenia, and you think it's aging related, then age is not the key factor, but the process is the key factor. So at the moment, if I'm very honest, I think we cannot apply it at this point in time because all the conditions already nearly have an ICD-10 code. So we already apply that. However, it's the first step. And I think the really nice thing is that's not age, but it's aging. So an aging is a process. And there needs to be lots of further conversations with the WHO, for example, to clearly define that. In
a way, when you think about it, it's just a place mark to say, yeah, we kind of get it. We're not sure what to do with it yet, but we kind of get the idea that aging is driving these diseases, right? Is that how you see it?
Yes, and I must say, I think we are also at the same stage. It's as researchers, I would say, I am as a clinician, I'm thinking also at the stage, what would I now do if I would have the ICD-10 code, I think, or 11 code? I would really now like to see much more evidence, bigger trials being conducted in a worldwide network. For also other specialities did that. I think we really have to do that. Mm-hmm. Big trials, and then outcomes, and see what the outcomes are, and then the implementation into to clinical practice. The step forward is actually spreading the word and actually saying what Geroscience is, preparing healthcare professionals in the healthcare system towards that hopefully very positive trials. But very essential, if I look back into the history of cardiology, of oncology, other specialties, we need bigger trials and we need trial networks. And that's hopefully something we can work on in Singapore.
Yeah, I hope so. Looking forward to it. And by that, I mean, I'm looking forward to having you do a lot of that work because, I just figured out that humans have 2 legs and mice have 4. So I'm still in the learning process on this.
Yeah. We can have some sessions.
Thanks.
To talk you through the human body.
Everybody talks about hallmarks and pillars of aging. And one of the things that a lot of us are thinking about now is there some kind of hierarchy to these hallmarks? Are some more important than others? Do some drive others? It's kind of like the question of chronic conditions driving others. I don't know what you think about that. And I want to bring that up also in the context of senescence, because you presented a lot of interesting data on that. And I know you think about that a lot. Where does senescence fit in this hierarchy? Is it all of aging? Is it 10% of aging? What's the story?
So first of all, if the researchers now here in the audience, please, if you look at different hallmarks of aging or pillars of aging, measure a couple of them and not just one, because what we learned from the past, if we just measure one, we cannot actually answer this question. So Brian, I cannot answer this question because I focus so much on senescence, which is such a pity. But looking at other literatures, I think senescence is just the end result, or it's a sort of phenotype of cells of different mechanisms before that which went wrong. I think that senescent cells have lots of epigenetic changes. They are very short telomeres, etc., etc. So that's also what I like on senescence, because it might be the overall phenotype of everything which went wrong. And then feeding into a senescent cell. So I don't have the answer. What I really think is that there are different clusters of phenotypes you see clinically in human beings, which are then also mirrored by different clusters of hallmarks, which are abnormal in these individuals. So that the idea we always had, or I at least had, one size fits all, and everybody gets metformin, might not be the right way. Same as we see in other specialties, that if you do an intervention and a treatment, that it might work for one group of individuals, but not for the other. So I think we have to make a deep dive into pathophysiological mechanisms and really clarify quite intensively what kind of mechanisms do lie behind a certain phenotype in human beings. That's the reason why I really would urge everybody not only to detect and measure what's the age and what's the sex of participants, but also what are other phenomena in these individuals, if these are humans, and to measure that, which means you have to measure cognitive functioning, physical functioning, cardiac functioning, metabolic functioning, etc., to get a good data set and then compare the biological phenotypes to it.
Yeah, I agree with that as well. I think that's a great answer. And I just want to add that just because your cat just walked past on the roof, don't ask for residuals for the cat. We're not providing them. Okay.
This cat is already 21 years, so
wow.
Yeah.
It gets around pretty well for a 21-year-old cat. Let me ask one more quick question, and then I'll turn it over to Bibek. And maybe this is a more of a problem of how the measurements are done, but it almost suggested that lower body strength is a bigger indicator of health than upper body strength. Is that really true, something you believe, or is that just the quality of the assessment? And what does it mean if it's true?
Look, if you look functionally, human beings work on 2 legs. So the lower body function is much more important compared to the upper function. So there's much more association with other relevant outcome parameters. So in all the studies, we see that the lower body function, for example, quadriceps strength, is much more associated with outcomes compared to hand grip strength. However, lots of studies in human beings measure the upper body because hand grip strength is so easy actually to test. So it's practicality versus what you really would like to know.
That's great. You know, I think I want to bring in one of our postdocs, Vivek Gianwali, and he's been looking at some questions from the audience. Vivek, do you have some burning questions for us?
Hi, Andrea. Thanks for such a nice presentation. And I have few questions from audience here. And you have worked in Netherlands, Australia, and now coming to Singapore. So in your experience, what similarities and difference you find in those countries in terms of healthcare and combating aging? And what are the challenges in the aging society like Singapore has to overcome to increase health span?
Lots of questions in one question.
Yeah.
So, first of all, I would like to answer the perception around aging. And that's very, very different when I compare Europe to, for example, Australia. If I am in the Netherlands or in Europe, there are lots of media requests because everybody wants to know everything about senescent cells and healthy longevity, about the latest successes of Geroscience, for example. Whereas in Australia, the media was very focused on nursing homes and on incontinence and dementia. So there is a different attraction of this very nice topic, healthy aging, in different countries. That also relates how we talk about healthy longevity of healthy aging, I would say, under healthcare professionals, which is much opener, I would say, in Europe compared to other countries. I'm not sure how it's in US, Brian, but maybe you can comment on that. So, of course, in Europe also, Geroscience is not embedded, but at least you can talk about it. And people and healthcare professionals, that would be my assumption, know much more about the topic compared to, for example, Australia, where I lived and worked. And that's also the same for New Zealand. Of course, they share so much. If I look at Singapore, and that's also so exciting to come to Singapore, is that there is so much involvement from all levels and all hierarchies within Singapore to want the population to age gracefully and in a healthy way, that there's so much stimuli to really create interventions, to create biomarkers, to work together. And it's Valhalla. It's very nice to join you, because you in Singapore, I think you realize that if we age as we do, we might lose some healthy life years. Is that the answer to your question?
Yes, exactly. We look forward for you to joining Singapore very soon. And recently in our studies, we found many like active volunteers. They participate and they are physically very fit. And next question is, what do you think in a private clinic setting to conduct this anti-aging assessment? What are the basic equipment the private clinics should have, at least to start this and practice this anti-aging in their?
Yeah. So first of all, I would urge everybody who would like to do and to come into the biogerontology field and implementing it into clinical practice is please implement something where there's evidence, and that's very important if we implement it into clinical practice. Then I would urge everybody to implement already what's known for 20 years, but not yet implemented, how to clinically phenotype individuals. For example, a very easy thing as the handheld dynamometer to measure hand grip strengths, to really get a very good clinical phenotypic understanding of the individuals you're going to treat. And also, if you treat individuals or you assess individuals, then treat, that you actually see if it's going better. Because even by a very easy walking speed test or a chair stand test or a hand grip strength test or a cognitive test, you get a very good understanding. And if you have a positive change, then it's also very likely that your cells are also healthier, because that's the consequence of it. Before actually going into epigenetic testing, RIM-age, etc., I think we are not at the stage yet where we should do it in general clinical practice. We should only do it if we also evaluate it academically in a research design.
And, as you know, that's something that we're really trying to do, is to compare these newer biologic aging markers like Grim age and the epigenetic clock with some of the more classical markers in our studies. So hopefully we can start to tease out the connectivity there. Bebek, you have other questions?
Yes, I have one more question. In your presentation, you mentioned that there was some repurposed drug, they improve cognition. And is there any optimal dose we use for those drugs to improve the cognition?
Yes and no. So of course, all these studies, most of them, they are 1/3 is not published, but the others you can find on PubMed, which were published quite recently. Every drug they were testing, of course, were tested with a certain dosage and with certain outcomes. So yes, there is of course a trade-off, but there's again not a one-size-fits-all. And where the field is not yet at the moment is, for example, to look at 5 randomized controlled trials using metformin and using a cognitive outcome or an aging outcome where we can do meta-analysis, or we can do sub-analysis of the individuals to actually see who are responder, who are non-responder. So we are not there yet. So hopefully in 5 years' time, we will have these studies and actually precisely in a personalized way give an indication of what kind of drug somebody should use and at what dosage and at what frequency. Because these are the ingredients. What dosage, frequency, and what is the period and when to start? Lots of questions.
I still have one more question. Do you support the use of DHEA in longevity effort? Look,
if you want replication of cells, then this is the way to go. However, there's also the chance of cancer. So I would not, because I'm standing here also as a physician, not recommend anybody at the moment to use it because we don't have the trials yet. And if you use that, you should actually do it in a combination in a trial to do it safely.
Maybe that gets to an interesting point, though, is, are we going to approach an age where people have options of different interventions that have different strengths and weaknesses, and maybe that educated people can make their own choices about where they should go?
Sure. Look, everybody is free to do something. The other hand side, if you're a physician, do you prescribe it? So
no,
then it's your responsibility.
Yeah.
Of course, everybody is free. And I know that lots of individuals take lots of different drugs. I think what we should do as a community, an academic community, is actually objectively seeing if there is a positive result and including these individuals, at least in an observational design, into studies to see if there is an effect and use the usage positively in research, in an observational design.
Well, thank you, Andrea.
That would be beautiful.
Thank you, Andrea. And we'll be seeing a lot more of you because I know you've agreed to host some of the shows in the future. So when people get tired of me, they can have you to look forward to. So that might be next week. So I'm just warning you. So we have no more shows this month. We have 2 shows in May. One on May 6th, it'll be Peter Fedichev of Gero, and he'll be telling us about big data, and they have a couple exciting papers coming out that he can talk about data on. And then on May 20th, we have Maximum, which are an investment team from Switzerland thinking about longevity. May 13th is a holiday, so we won't be having a show that day. Please use the panelists and all attendees button for comments and questions about the show. And we look forward to seeing you next month. I want to leave you with a video showing the things crazy aging people in Singapore do to promote healthy longevity. Thanks again, Andrea.
Thank you.
I get lost inside my thoughts.
Dr. Brian, how are you? Good. First time bungee jumping?
First time.
Are you ready for this one?
We'll find out.
Here we go.
Up on the brink. I tried so hard, but all these scars, they cut so deep, I bleed. I fell so fast from heaven, it's like someone clipped my wings. Now I'm falling, and I can't see the ground. Can we stop this gravity? It keeps bringing me down. I can't breathe.
All right, buddy, how's your job?
Great.
Great.
Yeah, fun. I wasn't scared at all after the first second.
I'm feeling like sunshine, like springtime, like something's in the water and I'm taking a deep dive. I'm feeling so weightless, like I'm gonna make it, and nothing in the universe can take this. I can see it clearly now, nothing gonna bring me down.